Okay, well, this is just something a little bit different for the end of the day. I've asked the speakers to be fairly extreme with their views and maybe go some way from what they actually believe, but just to stimulate some thought. We know that surgery offers patients the best chance of cure from lung cancer. GPs nowadays, they're sending more patients straight for CT scans, and if they get a CT scan with a suspected cancer, should they send them straight to the surgeon? Why refer them to the chest physician and have them wait a few months till they actually get to see a surgeon? Lower GI cancers, rectal cancers, they go to a colorectal surgeon straight away. Someone with a renal cell carcinoma goes straight to a urologist straight away. Why not do the same for lung cancer? So, over to you, Sasha.
So while we're setting this up, I've been asked to do this at relatively short notice. I suspect the person that they originally asked wasn't considered controversial enough, so and believe me, I am going to be controversial. So my viewpoint is all cancer patients should be seen first by the surgeon. I see ourselves as emperors. I'm looking around and watching other people fiddling while Rome is burning. The NHS is in a state of at least discomfort, and therefore there are several grounds I think we can definitely say bring them to me as a surgeon. The first is on compassionate grounds. I eat, live, drink, sleep, in some cases, surgery, and that's what a surgeon does. All they ever do is surgery. Either they actually do the operation, they do the clinic for the operation, they go to the MDT for the clinic for the operation, or they train in the operation. And let's face it, we've got an easy on call. We're not going to be distressed by many things. And this is us, busy away in our home environment. Okay? Think about the chest medicine people. All they ever do is chest medicine. Well, is that true? Because actually a lot of them are allied to medicine. And if you look at that, they have an enormous amount of distracting work that's thrown their way. Yes, they have to be involved in training. They have a ridiculous on-call. And this is the chest physician. Mistakes will be made, things will be forgotten, and I don't think it's fair to place further burdens on an already stretched workforce of chest physicians. And this is exhibited brilliantly by the 10 to 5 phone call about the patient who's been there the whole flipping week. Also, the referrals that are sent to us are not giving the information that's required. Here's Finnegal's law. The information you have is not what you want. The information you want is not what you need, and the information you need is not available. And that sums up a chest physician's referral to me. Look at other countries. As Mike has already said, patients go off with their own medical notes under their arm, and they go to the specialist of relevance. If they've got a headache, they go to a neurologist. If they've got a chest ache, they go to a chest surgeon. Right, the chest surgeon provides all diagnostic and therapeutic options. Think about the delay that is inbuilt. It is the unalienable right of every chest physician to plan and deliver delay into a patient's pathway. They have to see a patient in a clinic after every test that they have done. Whereas a surgeon, the emperor, is efficient. He's got a battery of tests that he wants done. He knows what the breaches are, and he knows fine well that the breaches are predominantly the physicians in the first place. The targets would be better met if the surgeon controls the whole damn thing. Now I move on, my analogies slightly move away from emperor, but international rescue, it's a little known fact that the thoracic surgeon is actually Thunderbird 6, and here he is. Okay? Whereas the physician, from an embryonic stage, is delay. 6 months for an appointment, if you can see that. Physicians also have reticence. They're naturally more careful as a breed. I'm not saying that we're careless, But look at the peripheral hospitals. They've got a reluctance to get people to the CTFNA, either because the radiologist isn't very good, or because they keep on getting skin fat and striated muscle. Think about the flexible bronchoscopy. No one's going to biopsy anything if it's going to bleed. So that will probably rule out a fair amount of proximal tumours. And of course, the chest physician will be swayed by well-marketed other therapies that we've discussed in this very room with SBRT. Right? The physicians ultimately want tissue. There's a lump in the chest, they want you to do a wedge biopsy. Yes, they're taking on new procedures, EBUS, medical thoracoscopy. But the fallback position of each of these procedures is call the surgeon. And of course, if there's something else to be done, like a pleurodesis in the terms of VATS pleural biopsy, call the surgeon. The surgeons have a luxury. We work in excellent units. We've got a full battery of testing departments. We've got the command to get fastest appointments. It's a good working relationship we have with all these departments, and there's definitely a wish to please us. There's speedy access to all other departments. Think of all the other stuff that you can get out of your tertiary referral hospital. We are masters of our universe. We have great capability. We're best placed to know our boundaries. We're wanting to expand those horizons, even if you accept that you have boundaries. The anaesthetist, as you can see here, blowing up his patient, is a different kettle of fish. But we know our anaesthetists. We know their foibles. We know what their capabilities are, and we know which testing they require. Think about the risk. It's all the surgeons. Do you see an anaesthetist or a chest physician? We're moving into data reporting, individual data reporting. We'll come to thoracic surgery eventually, right? You won't see their names on the little ticket. It's just us. So we are the best person to consider that risk. And of course, patients are sent to us if they're borderline in the first place. So my conclusion is, the patient wants to be cured or operated. I haven't yet met a patient who said, I hope I'm not operable. The majority of patients will come to us anyway, as I hope I've demonstrated. We offer a fast, efficient, knowledgeable, targeted service. Now I accept that my combatant will have plenty of knives to stick in my back. But, friends, Romans, physicians, give me your patience.
Thank you very much, Sasha. That was very entertaining. Let's go home now.
Could you give us an VTS meeting as well?
Now, Richard again has put this together at relatively short notice. He's going to just argue why that shouldn't be the case. It's a fairly convincing argument from Sasha that we should be seeing all these patients, getting to them and curing them of their cancer.
Right, good afternoon. My name is Richard Milton. You'll be pleased to hear that I'm going to keep this short. And I'd like to thank my colleague for basically supporting what I'm about to say. Should all patients with suspected lung cancer be referred straight to us? No. Shall I go on? What is the size of the problem? 2009, 41,000 new diagnoses of lung cancer. How many of us are there? About 70 thoracic surgeons in the UK, another 70 or so wannabe thoracic surgeons. Do we really want to be seeing over 41,000 patients? I put it to you that the pen is not mightier than the sword. This is our office, not sitting behind a desk. Hello there, how are you? Do you have any any pain in the chest? How far can you walk? How many cigarettes do you smoke?
on board already.
This is what we do. You know this data. Unfortunately, lung cancer is awful. There's no denying that. Our 5-year survival is not very good. In Leeds, we're trying to, well, I'll talk about that in a sec. You all know very well that survival is determined by stage. These figures are 12-month survival in Leeds, depending on the stage at presentation. Patients that present with stage 4 disease, they don't have a 5-year survival of 8%. Their median survival is 100 days. 100 days. If these patients come to your clinic and say, Mr. Stamenkovic, will I be here at Christmas? If they see him in January, they're not going to see Easter.
So that's a personal score.
But look, at the moment, over 70% of these patients are presenting with disease which is not curable. I know we can do palliative care. Some of my colleagues do it very well. But is that what we want to be doing? What about the resources? I have one clinic a week. Some of my colleagues, or some people, might have more than one clinic, might do a peripheral clinic. But is there really enough time in your week to see all these patients? Will you have the appropriate support? Do you want to be the gatekeepers? I would be concerned that if we are seeing all these patients, we're going to be offering surgery to people who clearly we will not benefit, and we will be doing added harm. In fact, out of the patients that present to a lung cancer fast-track clinic, only about a third of those actually turn out to have lung cancer. You all know the causes of solitary pulmonary nodules. So look, 2010, 4,700 or so patients had a potentially curable operation. 700 and odd patients had a similar thoracoscopic procedure. But that's not what we do. That's a small part of what we do. We are busy people. We do a lot of other things, and we owe it to all our patients to do the best care that we can. Currently, all these patients with proven or suspected lung cancer are discussed with us. We sit in an MDT. Resection rates are rising. From the Blue Book, we are doing better. There has been an increase in resections over the last decade, and we are getting better at it. The mortality is improving. This is a paper that's been presented here that just caught my eye. Impact of a surgical attendance. Possibly one of the best papers here. We know that having a surgeon at an MDT increases the number of patients who are being referred for surgery. Not just potentially curable surgery for a lung cancer, but access for any form of surgery, be it diagnostic and so on. So in conclusion, I would say the current system works. Already the volume of work is increasing, and we're getting better at it. I would go so far as to say we see too many people in clinic anyway. In fact, we are now, our patients post-surgery, we see them once, then they get followed up by the referring physician. So that we're not overburdened with all these patients, and we can devote more time to seeing people who will actually benefit. So we should be working with our colleagues, as we do, in an MDT, and continue what we're doing now to provide the best care for these patients. Thank you.
Thank you very much, Richard and Sasha, for very entertaining talks at the end of the day. I don't know if anyone has got any questions or comments on that.
I will add actually that, these patients are presenting very late. And so for the last couple of years we've been looking at this in Leeds. We've been trying to get members of the public to walk into a facility where they can have an x-ray, walk off the street. They do not need to be referred. We are trying to increase the number of patients presenting with early stage disease, potentially curable disease. The x-rays in Leeds have gone from something like 400 a month to something like 2,000 a month, and that's sustainable. All these patients have to be reviewed. Do we really want that? No. Let our chest physicians do it. Or Sasha.